Right. I'd like to talk to some of the papers we have been publishing recently. And I think this paper has a special place in my heart because it's very, very unusual. It's a quality assurance in psychiatric occupational therapy by treatment manuals. So this is a team by Professor Linden, who works in Berlin, and Jenny Hufenreuther and Josephine Otto. And what they've done is exceptional. They also work in a rehabilitation clinic, and in this place there are different patient groups, and these patient groups usually get different types of therapy. And in this case, they have three groups of people. People treatment as usual. This is what's usually an offer. Then they have a specific group of things which are very nice, supportive. I come back to that. And then another group, a resistant-oriented intervention, where people have to deal with challenges. So the question is, and what they're shown is, if they have these different groups, they can show that patients recognize and can recognize their type of treatment, which validates the treatment and makes it specific. So I'd like to go to the different types of groups, what's on offer. So the resistance groups would be frustration training, doing a difficult origami, work some with the soapstone, so some endurance, creating something, some accuracy training with cutting things, and goal and orientation and acceptance of undesired tasks. So working with hard wood, that's something where people should learn some resistance, and acceptance of stress and criticism. So when they do things. In the regeneration clinic group, it's more or less, recreational, talking about things, collection and planning of hobbies of activity, eating, having tea, coffee, some mindfulness, do some cooking, do some self-reliant things, relaxation issues, and trying to have some contact in some interaction. So the question is, what is the better intervention for people who have psychosomatic problems and depression? Nobody knows. But however, so when you have these two groups, and both groups more than 100 people, and control group, and what you can see then is that people after the group, they get questionnaires, and there's a reintegration questionnaires. We talked about pleasant things. We looked at differences between former and current pleasant activities. We plan pleasant activities, able to experience moments of indulgence, focus on eating as a pleasure, nice relaxation, conversation, liking talking to others, and all these things. And then the resistant groups, there were questions relating to I learned to improve my frustration tolerance, learn to improve my level of detachment when I get frustrated, my training will enhance my level of stamina. So everybody get all these questions. And what's the important part here, that the differences between the resistance group and the regeneration group were all significant. So that people could say they recognized which type of activity they did, and they appreciated or didn't appreciate. But the important point is that the intervention is perceived specifically for both of the groups. So that's more or less the important part. Even if you do a rehabilitation service in a big rehabilitation unit, you can start validating your interventions. This is what OT doesn't very often, occupational therapy doesn't very often, but I think this paper, and this is why I like it so much, is opening up the necessity and the possibility to assess OT interventions, to make them measurable, and to see whether they can be appropriately used by patients. And I think this is an interesting paper. If you want to read the details, please do so on the website of our journal, globalpsychiatry.co.uk. Thanks for your interest, and yeah, I'd love to see more studies like this. Bye-bye.